This conference will now be recorded.
So I think everybody knows, except possibly our new gent, that we do record these groups, and we do that because some people like to re-listen and some people can't make the meeting and they want to listen later. And then we have people who I think listen from all over the world, from what I can gather. Altogether, we have about 150 to 200 people that listen to these recordings each week right now. So if our new gent does not want to be identified as who he is or where he is, he can come up with a different name. We're happy to do that. Otherwise, we will call you by your name. So, is everything good? Can we go forward as is? Yes, I see him nodding. Okay, fine. Thank you to our sponsors, all of whom I met. So they are, and I have to think this through, Bayer, Johnson & Johnson, Myriad, Sumitovant, Blue Earth, Telix. I'm missing somebody.
Foundation Medicine.
Thank you very much. Foundation Medicine. Thank you, Dr. John. I didn't really meet with Foundation Medicine. They were because their people weren't there. I did meet with Pfizer. I think there's a good chance they'll come back into the fold. And we're working on Novartis, who have really put us through the ringer, but there's hope there too. So keep everything crossed, and maybe we'll add a couple over the course of this year. We have one new gentleman, and I suspect he comes from the support group that Len used to lead.
I don't
So
think
he knows him
David,
well.
Rick, I don't think David's going to be asking for himself. Are you, David?
No, as a matter of fact, I'm going to ask about a gentleman in our group who you and I had a very brief discussion about, Len.
Yeah. We don't do that, David. I'm afraid. We don't. If somebody because then the reason being that we're such a big group, we cannot. If somebody wants to come in, they can come in, but we don't ask for other people in this group. Otherwise, it would just get out. It would get crazy.
Sure, understandable. I think he's in the other room somehow. I'm not quite sure how this all works for you, but so I'll just keep quiet and listen in. Then that'll be fine.
Okay. When you say the other room, you mean our schmear room?
There were two rooms.
Yeah.
I
Well,
guess
why
that's
don't
correct. Yeah.
why don't you reach out to him? I mean, if you went in the other room, he won't find anybody there. But if he comes in this one, he'll find 40 people. So
Oh, well, then I'll try to direct him to this room.
Right.
Okay.
And if he comes in, give me a heads up, put a note in the chat window, and we'll revert to him and give him the time that he deserves.
Yeah, David,
Thank you.
I think I had recommended that you have him attend Peter Kafka's intermediate group. This is the advanced prostate cancer group.
Okay. Yeah, I wasn't clear. Okay. I got confused about that. Okay. And when is that, Len? I'm sorry to take time here, but
That's all right. Peter, why don't you let him know?
Next Monday at this time. Same room, same thing, next Monday at this time.
Terrific. Thank you so much, guys.
Second and fourth Mondays.
Yep. Got you. Thank you.
Okay. And you're very, very welcome to stay and contribute as we go through. So,
thank you.
So now we have plenty of time. So I should be able to get around everybody. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 people. We should have no problem without a new man.
Jimmy
And
Greenfield,
so,
Jimmy
yeah,
Greenfield just arrived.
but it's too late.
All
We
right.
have a 10-minute cutoff for a reason.
I don't have
And
anything.
well, it's just as well, because otherwise
If I did, I would have been on time.
I would have come to you right at the end. The reason we have the 10-minute cutoff again is because we have a lot of people and people have to get here on time. And if they come in late in this meeting, we will only poll them if we have time right at the end. And that's right up there at the top of the reminder. So everybody's welcome, but don't expect time if you come in a little late. David Muslin, you are up
I get to be first. Yeah, thank you.
Yes.
So in September of 23, September of 22, I had a episode where not an episode, before I get to the episode, let me tell you. So about September of 22, I went from Lupron and Abby to monotherapy darolutamide. And at the same time, I experienced what I then thought was a TIA that turned out to be what I believe is an ocular migraine. And I've had 3 episodes since I've gotten on darolutamide, and I'm also on a drug holiday, and I had 1 episode while I was on the drug holiday of ocular migraines. I'm just curious if anybody else experiences that.
David, would you describe what that feels like, what it looks like for you?
Sure. The first ocular migraine, I had it in my right eye, and it was like a curtain that came down halfway. It was black, down halfway in just the one eye. It lasted maybe 5 minutes. And I've had 3 of those in the last year and a half. And of that specific type of episode. But I also get not uncommon once a week, once every other week, where I get like a shining light or some lines that move around that also last about less than 5 minutes, and then they dissipate. So
Okay, well,
yep.
I did see we've got 2 people to contribute on this. The first is Mark Valens. Mark, go ahead, please.
Yeah, I've had those for years, and I don't get a painful headache. It's psychedelic, and I found out my sister gets it, and my father had them, and I just go in a dark room, and sometimes take an ibuprofen, and then in half an hour it's there. I'm okay again.
But they last a long time, though.
They can.
And David, they checked out your retina completely,
Yes.
and they didn't see anything that could pulling the retina away from the.
Nope.
No.
Been fine. Absolutely fine.
Peter.
Yeah, my partner Susan just started getting those about 3 weeks ago. She was in the ER last week with it. Yeah, she's going to eye doctors. She went to the heart doctor today. She's trying to figure out what to do. Hers lasts for maybe half an hour or more. Yesterday she had to lie down for a while before we went out to eat. So it's a new thing, and she has certainly not been on darolutamide.
Right. Thanks, guys. I asked Russell Schmulowitz, Dr. Schmulowitz, about it last week, and he doesn't see any connection at all between DARA or prostate cancer with ocular migraines, and it doesn't. They last 5 minutes, no pain, nothing. It's just like you say, a little psychedelic, but not what I want to be seeing these days. So other than that, that's it. That's what I got.
So, Len, you just posted something. What did you post in the chat?
Yeah, I just did a quick Google search, ocular migraine and darolutamide, and this article came up. Potential ophthalmologic side effects induced by, it says anti-neoplastic, but they cover enzalutamide and other receptor blockers as causing some type of ophthalmology pathology, but I'm not sure that they actually mention ocular migraine. But anyway, if you have some time, take a look at it, David.
And just for everybody's information, I think everybody knows where the chat window is. It's the little box, the two little boxes, and if you click on that link, it will definitely open in your browser window, and you can read it later. So you don't have to copy down. You don't have to copy the link down. Now, we have two hands that are up, but I just want to make a comment here. We know that enzalutamide has a very small incidence of possible strokes because they came up during the original trials, and it seems to be more of a threat or a promise than something that actually happens. We also know that darolutamide doesn't cross the blood-brain barrier. So I doubt that it has anything to do. I'd have to, I understand where Shmulewitz is coming from, and I doubt it has anything to do with it. But I don't know. Maybe this article, David, that Len posted is worth a read, and I'm forwarding it on to Dr. S. Jerry Grimes, you have your hand up.
I do. I have a history of ocular migraines most of my life. I know very much what they look like. The visual aura, it starts, develops, takes time. The two things you're describing, a black curtain effect, is absolutely not an ocular migraine. That is a symptom of retinal detachment, and that's an emergency situation. And if that's happening, you need to see an ophthalmologist. The other one is the occasional flashing, again, also lasting about just a few minutes. Those are symptoms of what's called vitreous detachment, where the vitreous humor, I think they call it, inside the eye, is separating away from the retina. It's not necessarily harmful. Mine are both completely separated. The ophthalmologist doesn't raise a concern about it. But the two things you're describing, I personally don't see how they're related to anything to do with prostate cancer. And they are both warning signs that you really need to see an ophthalmologist, not an optometrist, an actual eye doctor, an ophthalmologist, probably a retina specialist.
I agree. And as you described it, the retinal pulling in the flashing lights is classic. And that's just the vitreous trying to release itself from the
exactly.
Yeah, but the other one, the shade going down, is symptomatic of a detachment, except it's usually not short-lived, and that's where it's confusing.
That's
because
true.
So it sounds you have to get a retinologist to look at this and look more closely and get fully dilated and let him look at the periphery and see exactly what's going on if you have any tugging, and he has to watch that very closely. If you get a retinal detachment, that could be very problematic. So I think you should, even though you said you would check that, David, I'd get it checked out by a retinologist.
Yeah, I've had a neuro ocular guy look at it, but and when I was at Northwest, the first time it happened, I thought it was a TIA, and they thought it was a TIA. But because I've had it numerous times and I've had a complete cardiologist check me out, my heart is fine. I have no blockages, nothing. Just trying to sort out why this happens. And I think a retinologist may be a good idea. Thanks, Jack.
You can have temporary situations like that when you have sludging of blood, when you have, let's say, you're dehydrated, or you're just, a little bit of coagulation. It's very temporary and it doesn't last long. And you get the window shade or the quadrant. One of the quadrants go blind, and
Yep.
That happens, and it only lasts several minutes at the most. And then the
So,
sludge gets released, and then it goes away.
And you say that can happen from dehydration.
Yeah, dehydration can do it, or your platelets start to build up on themselves, and who knows what darolutamide can do to platelets? If it can do what it can do to white blood cells, I wouldn't be surprised if it can alter the platelets and cause some sludging. But
So I'm David. You've seen that Dr. Len is chasing me up. You might want to he owes us one because I'm going to talk to him. So you
Yep.
might want to give Dr. Len a call and ask him. And I definitely endorse the retinologist. But why don't you pick Len's brain as well?
I think it's a great idea. Thank you, Rick.
Okay.
Thanks,
Okay.
Dr. J.
David, I just searched on after I heard Jack's talk and the other fellow talk about retinal detachment. I searched the document for just the word retinal, and it comes up 48 times. I saw retinal occlusion, retinal hemorrhage. So, yeah, bring that article to your doc's attention.
Will do. Thanks so much, guys. Thanks, Len.
Pleasure. All right, moving right along. And the next person on my list is Neil Sundstrom in weather-torn Silicon Valley.
Yeah, it's still raining. Again. Yeah, thanks. I wanted to kind of give an update, and I got some questions regarding a follow-up that I had with my urologist. I don't have any other doctor that I go to outside of my urologist. And just as a background, in 2013, I had my prostate taken out by Dr. Carroll, and lucky me, 9.5 years later, my PSA started rising, not very far, to 0.15 was the most. And my urologist and I decided we'd go for external beam. So we did a external beam in May and June of this year, 39 treatments. I started on Orgovyx in the middle of April, about 2 weeks prior to that. And so it seems to be relatively under control. I'm looking at less than 0.04 in May, June, through October, through now. I had a blood test. I've had 3 or 4 blood tests since the external beam, and they've all been 0.04 or less. So I had a meeting with my urologist, and he said to me, "Well, what about the Lupron shots?" And I said, "Well, I didn't have Lupron." And he said, "Well, yeah, the shots you had, when we first started all this." And I said, "No, you didn't prescribe any Lupron, and I didn't get any shots here." So I kind of sat back and thought about that, and have a couple of questions into him about that. First of all, is that the standard of care to have the dual drugs, Lupron and Orgovyx, the Orgovyx I'm taking? And then secondly, why didn't he prescribe it? I've got that question into him. I'm expecting a call tomorrow from him on that. And lastly, should I be getting Lupron now? And is that something that I should be taking at this time? I'm going with the Orgovyx until October, which will be 18 months. First of all, and then he said, "Well, you're undetectable, so you're okay." And I said, "I'm not undetectable. I'm at 0.04 because I've been less than 0.01 prior to this for 9 years." So I'm, first of all, I'm very disappointed in the urologist, and obviously he's not paying attention to my situation. And so a couple of questions. First of all, is the standard of care that Lupron and an ADT drug like Orgovyx is prescribed for the external beam? That's my first question. And second question is Lupron something I should be taking now if that's the standard of care? And
So,
lastly, where do I go to get rid of this urologist and find someone that's competent?
okay. So you've heard us say enough times, I think, that when it comes to follow-up care, you got to dump your urologist. And I know we've talked about this before. This is not who you want. Okay. You should have a genitourinary medical oncologist on your team.
Yep,
And you can find one at UCSF.
that's where I
There are
want
a
to go.
couple of there are a couple of other places around. Stanford has, but there's nobody for us that really stands out at Stanford. And there's no one else that really stands out anywhere else in the Bay Area other than UCSF, although there are a couple of others. And I'll come back to names in a moment. As far as do you need Lupron and Orgovyx? Absolutely not, because they do exactly the same thing. They just do it in a different fashion. The Lupron is what's called an agonist LHRH drug, and Orgovyx is an antagonist LHRH drug. I won't get into the technicalities of that, but they work in different fashion. And Lupron is an injection, whilst Orgovyx is a pill. And what we seem to think, and we've encouraged Sumitovant to do better studies, is that the return of testosterone, well, first of all, it stops the testosterone quicker, and the testosterone returns quicker. So if you can get it, we think it's a better drug. We think it's a better drug in that category. You absolutely don't need both. And clearly your urologist has trouble understanding what these drugs do, because yes, of course you're at 0.04 because you're on ADT. And if the ADT was not working, then your testosterone would be rising. So it's not surprising you've been at 0.04 since you started taking the Orgovyx, because that's exactly what the Orgovyx is supposed to do.
Mm-hmm.
And we won't really know how successful your treatment's been until you come off, whenever it is in the summer.
Right, that'll be October, and so I hope to certainly have a GU by then to go
Well,
through this.
I think you need to get a GU on your team. Talk to Dr. Carroll.
Yeah,
We would recommend probably Rahul Agarwal. We like Aggarwal.
yeah,
He knows us real well. He's very solid. He has a specialty, which thank God you don't need, in neoendocrine, but he's really, really good. If you could get in to see Dr. Borno, who Mark Valen sees, she's lovely. I just met with her, but she's not really taking new patients, but she would be a good fit for you if Peter can get you in to see her. I personally like Terry Friedlander very much, Friedlander. He does prostate and he does bladder. He's probably the best guy for bladder at UCSF, but he does prostate too, and some of our guys see him. There are a couple of others who I don't really know. They're newer.
well, I'd heard
There's a
Agarwal
couple.
before. I'd heard Agarwal before, and I was when I was looking at the GUs that I kind of honed in on him to take a look at. So I'll call Dr. Carroll and see who he recommends, and perhaps give him a couple of these and see if I can get in. I appreciate the help there.
Anybody else have anything they'd like to say to Neil, other than to make sure his umbrella is handy?
I'm from the Pacific Northwest. This is nothing.
No?
Well, thank you.
All
Appreciate
right.
it.
Okay. Org and Lupron. Sorry, I'm just making notes because I'm gonna have to post all this tomorrow, so I make notes as I go. Who's next? Hold on a minute. Next on my list is Frank Fabish.
I had my 8-week follow-up with my oncologist on Tuesday and a blood draw. All the blood work was positive, stable, but my PSA went from the last time from 0.33 to 9.97. So even though it's still a small amount and under 1, it tripled in 2 months. So what my doc has ordered, we talked and he set me up immediately for a PSMA scan come the 14th of the month, and to meet with him the day after the PSMA scan. He wants to make sure that the cancer hasn't metastasized someplace else beside my lungs. And at that point in time, then he wants to discuss a change in treatment, of which 2 possibilities are going to arise. One is Pluvicto, and the second one is going to be the PARP inhibitors. My big question right now is for anybody that's been on Pluvicto, what has the treatment been like, and what are the side effects from that treatment?
Okay, first of all, can I see a show of hands as to who on the call has had Pluvicto this week? Do we have anybody? It doesn't look like we do.
That's
Although,
surprising.
yes, it is surprising. So I'm going to kick this off, and then I'll let the other moderators who are very familiar with Pluvicto chime in, and anybody else who wants to say. First of all, I think Dr. I always forget his name, Amir, what's his last name?
Mortazavi.
Mortazavi, yeah. He's right on the ball. That's exactly what you need as a PSMA scan. And he's coming up with the right alternatives. Although you may want to add cabazitaxel to that as well. As much as you don't want to hear that, it might be another alternative. Secondly, what I would suggest is go back into our recordings, and there are plenty of people that have talked about Pluvicto. So if you go into the recordings, and you can even search for Pluvicto on our website, and it'll bring up, I hate to think, probably 40 different recordings. But if you search for Pluvicto on the AnCan website, you'll find loads of information. I think a couple of weeks ago, maybe even the last meeting, somebody had that question, and Al Latimer and somebody else responded at length about Pluvicto treatment. So rather than us trying to tell you, I would say that's probably, if you want to hear it from the horse's mouth, check it out on the recording. That's another reason why we record these groups. So different people respond different ways. There was a poster about how, by and large, bone pain is limited to the first treatment of Pluvicto and not thereafter. It was a poster that came out of University of Kansas. I forget the guy's name, Lee, I think. I don't know. I made a note of it. I think I might even have taken a picture of it. And I told him, look, we've seen people have bone pain from Pluvicto longer than the first. I can think of one person who had it all the way through to the fourth, but it's unusual. And usually, if people do have bone pain, it's usually right at the beginning. The biggest issue usually is around dry mouth and throat issues, because I always say the esophagus, but it isn't the esophagus, is it, Len? What is it that you're muted, Len?
The pharynx.
Yes.
Yeah, salivary glands.
Is the salivary glands, right? The salivary glands exhibit PSMA. We're not really sure why, but they do. And so the Pluvicto can affect the salivary glands. So that's another side effect. Fatigue is a side effect. Nausea can be a side effect for some people. Not that frequent. But Frank, do you have a palliative care doc on your team?
Not yet.
Okay, you gotta put one on. You've heard us say it enough times, and you need a palliative care doc, because they're going to help you with all these quality of life issues, and they're probably going to know more about how to treat nausea and how to treat pain than Dr. Mordasavi does, even though he may think he knows more. Because those palliative care docs, that's their job. And that's why we want you to have it. And if and they'll be right there for you if you've got issues like this. So
The VA has offered that about a year and a half ago. I hadn't taken them up on it because I really wasn't, I really didn't require that at this time,
Okay.
or at that time.
Yeah, but I wouldn't do it at the VA. I do it at the James, because you're getting treated at the James. So that's really where, and James is going to have a whole bunch of palliative care docs. If you find any that trained at UCSF or trained at MSKCC, I'd grab them, or even Dana-Farber, because those are like the best folks. And those are the best places in my view, for palliative care. So I always look to see where they trained, and because then we know who they trained with, and they're real good people. But everybody in this group needs a palliative care doc on their team. Everybody. This is not end of life. This is quality of life. We say it enough times here. I wrote about it in a weeks ago. It's so important, and the ASCO guidelines recommend that you have a palliative care doc on your team for when you need it. Because the problem is, if you need one and you don't have one, it's hard to get one set up right away. But if you're on a treatment and all of a sudden you're getting rotten nausea or fatigue or muscle pain, that's what you need. Because if you go to your doc, if you go to your oncologist, they're going to say, yeah, well, this is a side effect. Well, thank you. What can we do about it? Oh, we'll take a couple of ibuprofen, Or worse still, I'll give you some OxyContin. You may not need OxyContin, but the doctors, the palliative care docs know what to do. They know there's more than 2 drugs or 3 drugs for pain. Dr. John can talk to that in detail. Maybe we'll go to Dr. John. Les, you have your hand up.
Yes, I did have Pluvicto, but I only went through 3 sessions, and I didn't really have anything to add, but I had gone through 3 sessions anyway.
And what were your side effects?
Nothing that I really know of. My fatigue or lack of endurance was about the same as it had been, which was very high. But as far as the other things, it didn't seem to change anything.
Thanks.
It's just they quit because it didn't seem to be doing anything.
Right.
Dr. Oliver Sarter decided that had enough.
Right. Well, not everybody produces PSMA, and some prostate cancer that produces PSMA early on may not produce PSMA later in life. Some of you may have watched the prostate webinar in which Dr. Sartor participated last week, and so did Emmett, Dr. Emmett, Laura Emmett, and she has been running a trial in Australia where they add enzalutamide to Pluvicto earlier in the disease cycle before chemotherapy. And it's been a very, very successful trial. And the reason they think it works is because the more advanced the prostate cancer becomes, the more PSMA it produces, and therefore the Pluvicto can pick off these more advanced cells. However, what I pointed out in the chat is it all fails because at some point they become so advanced that they stop producing PSMA altogether. And there was another poster at GU ASCO about what do you do after. But I'm not going to give you all the goodies at one time. You'll have to wait. I'll come back to that one because that is a real important one. So we'll be coming back to what happened, what you do after, and when you should do your chemotherapy. We can't give the shop away in the first 53 minutes of this right now. So, Frank, anybody else have anything they want to say to Frank? Okay, moving right along, Dr. Jack.
I'm okay. I said I didn't have anything tonight.
Oh, I thought you said you did. Sorry.
No, I was last week.
Okay. Okay, Joe Commander.
Hello. I finally have some activity to report, I guess you would say. I had, since 2021, I've had what you would call oligometastasis, which means we found one lesion at a time in, what do you call them, lymph nodes in the pelvic area, I guess you'd say. And so I had one radiated with SBRT back in 2021, the summer of 2021. And my prostate went down, my PSA went down from about 1.5 or so to, it wasn't undetectable, but it went down pretty low, below 1. came back. This in 2023, about the same time of year, so it was this late spring, summer. We found another one on a PSMA test, and I had that radiated as well. It was about 1.5 before the radiation, went down to 1.3. Oh, I don't have a prostate, by the way. Went down to 1.3, which is not very low, and in October, and just now in late January it went up to 1.9, which is the highest it's been since I had my prostatectomy. I talked to my medical oncologist on Friday, and what we're inclined to do is get another PSMA test, which will be at the end of February, and see where we're at. And if it's still just a spot or two, we can radiate again. That's kind of the idea. If not, I guess we're looking at hormone therapy of some kind. I don't know if you have any comments or suggestions, or you just want to hear it, or what you want to do.
Were you already on hormone therapy after your
No,
radical
I've never had it.
prostatectomy? Oh, you never had it?
No.
Okay.
What
I've
was your recent
had
story?
radiation of the prostate bed after the prostatectomy, about
Yeah.
3 years after that. I've been dealing with this since 2013.
Yeah.
4 plus 3, Len.
4 plus 3. Okay.
Look, you're dodging the bullet and you're doing a great job. I mean, I think
I'm
anybody
doing what I
who's
can, you know. It's sort of
well, you're doing a great job. I mean, anybody who had salvage radiation first time in 2017 and has gone 6 years without having to do any hormone therapy, if I ask for a show of hands here, I don't think there's anybody who would say you're not doing a great job. Anybody think he's not doing a great job? I think he's amazing. 6 years out, no hormone
well, I
therapy.
can't say I accomplished any of it, you know, but
Well, but it's great. So, unfortunately, at some point, some type of hormone therapy is probably inevitable. I hate to say it,
right,
and I know you don't want to do it, but
right,
it's probably inevitable.
right.
And what your doc's doing is great. Is it Catalia? That's what I've got
Yes,
noted. Yeah,
yes,
okay.
that's correct.
Yeah, I don't know her. She's at
Yeah.
Fox Chase. I don't know her, but
Right.
she's doing all the right things.
Mhm.
That's what those are my comments. Alan Babcock, go ahead.
Yeah, so I just want to say, you said you haven't done anything, and I know it can feel that way, but what my medical oncologist told me, he said, Alan, you do everything to fight this disease. So change your diet, which I did, exercise your ass off, which I've been doing, get your stress down, retire, and, start enjoying. And he said, you have to do everything you possibly can because your body then fights it off better. So I'm betting that you've done a lot of things right. And that's why you held it off. So
Well,
give
I
yourself
do
some credit.
exercise a lot, and I'm pretty careful with my diet. Always have been. In
Yeah,
fact,
so
I have a
give
question
yourself
about
some credit.
exercise.
That's a good point, Alan.
If I could ask about it. I certainly have heard the word that I need to exercise, and I've started lifting weights, which I never did in my life because who wants to lift weights? I've run a lot. I've always run, and so I keep doing that or walking. But I don't know how much to do. I mean, I've heard people say they do this until they drop, and I'm not really. As much as I exercise, I never do anything until I drop.
Okay, so Jimmy, you're restricted to 3 minutes max because we've still got a lot of people, but I'm going to
Yeah.
let you respond to Joe.
How kind of you. Listen, I don't have a lot to say. You painted the picture perfectly, Joe. Consistency is more important than intensity. Intensity
Okay.
is wonderful. Consistency is everything. If you're doing it regularly and you've been doing it regularly, and especially if you have beautiful white hair and a white beard, it's strongly to your advantage. And I don't really have a whole lot to say. I do think, being an exercise guy myself, yeah, I always often I walk out of the gym saying, man, I really left about 20% out there on the table that I didn't get done today. And I feel real bad about that for about 10 seconds. And then I go on. And I'm doing better than average by far. And I really, really strongly believe that we always talking about getting back in the gym. I'm going to get a trainer. I'm going to do this. I'm getting ready to do that. But you're doing it. And doing it is what counts. And that's all I got.
Anybody have anything else to
May-
add?
Maybe
I was
about
gonna
300
say,
minutes a week as a general guide.
So, sorry, John, Jeff will come to you. Dr. John, please repeat that.
Maybe about 300 minutes a week if you want a general guide.
300 minutes a week
Yeah, something like
of
that.
exercise. Okay.
Yeah.
I probably don't do quite that much, but
I mean, that's great if you can do it, but I will say John's probably, I mean, I've seen 2.5 hours of strenuous is what I've seen, which is 150 minutes. So John's
150.
doubling that, which can't hurt you, but I think
No.
the general rule that I see is 150 minutes of strenuous exercise.
Okay.
I think
Jeff
Len was
Wood.
gonna say- Oh,
yeah, I was just going to say, your gym certainly has trainers that are available. It's worth, buying a session or two and getting their opinion to design a program for you, and just give you some other feedback.
Okay.
It's a good point, and I just want to mention that the American Society of Sports Medicine has a register of people that have specific cancer training.
Okay. You gonna put that in the chat?
Well, I don't know if I can do, because I'm moderating today, so I can't.
Okay.
It's hard for me to find it right now.
Repeat the name again. What was American?
The American Society of Sports Medicine. If I can find it quickly while someone's talking, I will
that's
definitely.
good enough for me.
Okay, and they have a register, and I'm trying right now. American Society. I'm trying to see if I can pull it up on my no, it's not coming up. American Society of Sports Medicine, AS Society, ASSM. Does that come up? No. Okay. Let me see if trainers. I'm not going to be able to find it quickly.
That's fine.
I'm afraid. Sorry, but I know I have it bookmarked. I do know I have it bookmarked. Dr. John, you wanted to say something?
No.
No? Okay. All right. Anyone else? Oh, look at that. Bill Lee, God bless him. Thank you very much. Put it out there. But I actually have the link to the register. But you're on the way with what Bill Lee put in there,
thank
and
you.
I'll see if I can find it, or if I try to remember when I'm writing it up. If I see it tomorrow, Joe, when I have time to breathe, I'll send it to you.
Okay, thank you.
And I like what I like. A trainer's a great idea, but I think it's really important to have a trainer who understands cancer.
Yeah,
It's
I was
less
hoping for that.
important. when you're not on hormone therapy. But, you know, I just think it's a good idea. Anyone else have anything they want to add?
Rick, Neil's got his hand up.
Oh, Neil, go ahead. Thank you.
Yeah. So Joe, I am on the hormone therapy, as I said earlier, and boy, when I exercise, and I exercise 4 days a week, 5 days a week, I feel much, much better. And that includes some weight training. I wouldn't call it heavy weight training, but certainly some kind of weight training to just make sure that the muscle tone stays in my upper body as well. But most of my exercises on the bikes and things like that. So whether it's riding a bike outside or running as you do, but putting it together with some of the other inside activities of some weight activity for me has just every day I do it, it just feels so much better than if I don't.
Thank you.
Okay, well, that was very helpful because it gave me time to find the link. And it's actually the American College of Sports Medicine.
Oh, it's a different one. Okay.
And it's different. And here's the link to everybody. It's right there. And that's what I was thinking of, the American College of Sports Medicine. When I got that part right, I got everybody. I got it for you.
Okay, thank you.
So you can click on that and you'll be able to put in Philadelphia and you'll see who's trained in your area,
Okay.
who's got that training. And I've been working with ACSM trainers since 2008. In fact, the first 2 people to ever get certified, I knew, one I still keep in touch with. And it's a very good certification. And by the way, they have certifications for other conditions too, if you know people that are looking for specialized trainers, not just cancer. Okay. I'm moving along. And I'm moving to somebody who just spoke, Jeff Wood.
As I approach a PSA of 1 with a recommendation to go on Orgovyx, and that would be the second time I've been on ADT, is there any research that, instead of going back to a first line, skip and go to a second line as opposed to going back to a first line? Does that ever happen? Does it ever get recommended?
So, we really need to know how extensive your disease is, your condition is at this point in time. So before you go back, I'm assuming that you'll do a PSMA scan. Is that a fair assumption?
It's been done and nothing found.
Okay, but as you get closer again, at what level did they do it, Jeff? Where was your PSA?
At 0.63.
Okay, so the chances are that your doc should be ordering it again before they put you on the HT. And at 1, they may find something. Just because they didn't find it at 0.63 doesn't mean they won't find it at 1. Right?
Right.
Now, depending on what they find indicates what treatment you should go on. And today, they tend to put people with low volume disease on 2 drugs, not 1. They put you on an LHRH drug, whether it be Orgovyx or whatever it is, or Lupron or whatever they choose, and they should put you on a second-line antiandrogen because that's the standard of care now. It's no longer just a single hormone therapy. If you have multiple at this point in time, they would add chemo. But that's probably not going to be your situation. Now, the real question is there any value in doing monotherapy? And how about just enzalutamide or just darolutamide or just abiraterone or apalutamide? And some of the really good GU medoncs might consider that, especially if you had comorbidities that had issues around the LHRH. Like I was contacted this week by a good close friend of mine whose cousin just got diagnosed in the Phoenix area and has diabetes. So maybe somebody like that, if the guy's with a really good doc, might consider a monotherapy second-line antiandrogen and skip the hormone therapy. And what I suggested is I suggested a doctor and I suggested that they discuss it. And the doctor I suggested would be willing to discuss it. The doctor I think he's seeing, I doubt will, because it's not the protocol. So I don't know if that answers your question, but I think the most important thing for you, Jeff, is to be sure you get another PSMA scan before you start any form of hormone therapy.
How close together can you do it? I did it in October.
Well, I mean, if your PSA's gone from 0.63 to close to what is it right now?
Unknown until next week, but my last one was 0.63 at the point that I got the PSMA scan. That was October.
Okay, so I think we're sort of jumping the gun a little bit, but I think if it's continuing to rise, it may have gone down. We don't know. But when you say it's getting close to 1, there's quite a good gap between 0.63 and 1.
Yep.
Anybody else want to add anything to Len? You have anything you want to add, or Dr. John?
Well, it is time for another PSA test. Sorry, Len. Yeah.
Oh, go ahead, John.
I was just going to say it is time for another PSA test. It's been 3 months. Should get one now.
Yeah, well, I'm scheduled for next week.
Okay.
Yeah.
Len?
Yeah, I agree with Rick completely. You can't just assume that it's going to be 1 the next time you do your PSA. My PSA was rising steadily from less than 0.1 to 0.65 a few years ago, and I expected it to continue on its march up, but it just stayed there at 0.6 for close to a year. And then it started going up again, but you just don't know.
Yeah. It's been a pretty slow, steady in one direction kind of thing. It stalled for 3 months. Yeah. But next week will tell where I'm at.
And then come back and talk to us.
Absolutely.
And who are you? Who's your quarterback right now?
In the process of transferring to Dana Rathkoff at MSK.
Good move.
Yeah. She's going to give me a second opinion later this month on the same questions that I have.
Good move. I think I've said this before. It's a bit embarrassing, but a very good friend of David Muslin's has known Dana Rathkoff since she was in a stroller. So, just saying. So, he's very friendly. They're very friendly with her parents. So we told him we love her. So, okay. Anybody else, or can I move along? Okay. Darryl Rohrer.
It was close. It's Roar.
Roar.
Yeah.
Come on down.
Yeah. And this is just to refresh you, Rick and Peter, this is my second time I was in your group, January 15th. I'd like to give an update and then get feedback from all of you. I'm being seen by Dr. Kyriakopoulos, a GU oncologist at UW-Madison Hospital in Madison, Wisconsin. I just finished docetaxel, 6 rounds on December 18th. Met with Dr. Kyriakopoulos a week ago today, January 29th. And following on January 25th, I had a CT scan and a bone scan. And I've just had my wife come in, just Annie, to listen in on the conversation.
Sure.
Okay.
Welcome, Annie.
So, anyway, following the CT scan and the bone scan, the results did not appear to be too favorable. He had a number of concerns, is the word he kept using, about spots. My torso region had numerous spots. So from that, I have a PSMA PET scan a day after tomorrow. And as soon as they get that read, I'll do a bone biopsy. And then they've tentatively scheduled me with a radiologist if I'm a candidate for some type of radiation therapy for the 21st of February. So that's kind of an update. Is there other information? Oh, and my PSA has continued to go up. The last 3 or 4 blood draws from below I was down to 0.0 something, then creeping up to like 0.3, 0.5, 0.68, and then the most recent one was 1.4, I think.
So I have a few questions here.
Okay.
And I just want to be clear. So you did say, because my notes were wrong. You say that you've completed 6 rounds of chemo. Is that right?
Correct.
And you completed those in January. Is that right?
December 18th was my last round.
Okay. So
docetaxel.
Right. Now.
Oh, and I'm also on Lupron. I just got another injection last week, and I'm also on darolutamide, and I've been on both of those since August.
Right. I don't know if I had. Yes, I had triplet, but I didn't have darolutamide, so I'm going to put that in. The discussion I'd be having with Dr. Kyriakopoulos.
Dr. K is good.
Kyriakopoulos, yes. I'll have to call my friend Dr. E and have her teach me how to say that properly.
There you go.
The discussion I'd be having is, since the chemo didn't do the job, the next step, he's talking about of switching your, he's saying let's switch your drugs, right? Isn't that what you just said?
No. We're doing the PSMA PET scan day after tomorrow.
He's talking about spot radiation as the next step.
Okay, and then a bone biopsy, and then this possible radiation. I have an appointment tentatively for the 21st of February.
Right. Number one, I have no idea why he's doing a bone biopsy, because it's uncomfortable and inconvenient for you, and a liquid biopsy is a lot easier and will probably produce the same results. And that's what we seem to think today. I mean, we don't need to go hammering in on these lesions, when we can do a liquid biopsy and see what your produce a somatic test. And the liquid biopsy probably gives a better result than the bone biopsy, because when they do a bone biopsy, they have to macerate the bone, break it down. And when you break it down, we think you may lose something. Whereas if they can pick up enough, which they should be able to in your situation, from a liquid biopsy and from the ctDNA, and they analyze that, they probably get a more accurate result. That's the thinking with people like Tempus and Foundation Medicine today. And that's the thinking of the better GU medical oncologists.
I will talk to the nurse navigator tomorrow. We talk almost every day right now.
Okay, well, again, the nurse navigator may not be on top of it. But I think that if it were me, I would be saying, I don't want a bone biopsy. I want a liquid. I want a liquid biopsy. And I don't want that liquid biopsy to go to Guardant 360. I want it to go to Caris or Tempus or FMI, Foundation Medicine.
Caris, you said, or Tempus?
Caris, C-A-R-U-S, C-A-R-I-S, Tempus, T-E-M-P-U-S, or Foundation Medicine.
Okay.
Or Myriad. Myriad also has a decent test. We think it's pretty good, but it hasn't been around as long. But if it were me, I would probably send it to Tempus or Foundation Medicine.
Okay.
Now, we really need to see what that shows, because you may be a candidate for precision medicine. Here's another gem from GU ASCO. This one's pretty amazing. But 80% of men with metastatic castrate-resistant prostate cancer have never received germline or somatic testing. Scary, huh? So Carbone is doing something right, because they are ordering tests.
Yeah.
Even if they want to put you, even if they want they want to put you through a little bit of torture to do it, which they don't need to do. But at least because you don't know, you can't tell if somebody needs a precision drug if you haven't done any testing. So it's really good. Now, one option that might come up. I should have asked you, are you in any pain?
Yes.
Where?
I have a spot from my chest to my lower, I'm blanking. Shoulder blade in the back. And it's progressively gotten worse. And then my lower back along my spine. And,
Okay.
and just, I think some of the muscles around that, just because I'm so uncomfortable.
Right. So, there's an argument that they could give you palliative RT, radiation therapy, which is what Kyriakopoulos is talking about. I got it better that time, Kyriakopoulos.
Yeah,
I got the right
there.
rhythm. I got the right rhythm on that one, right? So, there's an argument as to why he wants to do that. But for me, you're probably a great candidate for Pluvicto at this point in time.
He talked about that.
That's where I would be going, which is the radionuclide medicine, provided that you're PSMA positive. Have you had PSMA scans before?
One back in August when I started. And in my chart, Annie just said, I had forgotten this, he has talked about Pluvicto as a possibility.
Good job, Annie.
She's my case manager.
I know. So to me, that's what I would say. And I'm now going to let other people have a shot at you.
Okay.
Who wants to start? I take the low-hanging fruit, you see. That's what I do. And then I give it to the rest of my brains trust, and they come in with whatever's there. But that's because I'm leading today. If I wasn't leading, I wouldn't have that luxury. They'd get it. Go ahead, Len. You got your mic on.
Well, I'll go for that low-hanging fruit too and say that I agree with what you've been talking about here. Probably ctDNA or liquid biopsy better than the bone biopsy. Coming out of ASCO GU just last week, the options for metastatic castrate-resistant prostate cancer is, well, if you have pain, chemotherapy, but you just had that, so maybe that wouldn't be right for you. Or the radioligand therapies like Pluvicto, or possibly even actinium 225, which I heard from the conference is actually better for micrometastases. So we'll have to wait and see what your PSMA scan shows because of a phenomenon called crossfire. And of course, if you do in fact have bone pain and your metastases are just about exclusively in the bone, then radium-223 is an option for you also.
Okay.
Yeah. Now, unfortunately, every option for advanced prostate cancer that is not targeting the androgen receptor is myelosuppressive. So, they have to consider.
Can you explain what that means, Lynn?
So you'd have to take a look at your hemoglobin, your hematocrit, your white blood cells. If they are platelets, if those numbers are all depressed, then they have to be a little cautious with all these other therapies because they will further suppress your bone marrow.
I don't believe they have been suppressed.
Your red blood.
Yeah.
You don't think so?
Well, were they? This time they were low.
White was high, red and platelets, or hematocrit and platelets were low.
Yeah. How low are the platelets?
Oh, I don't know. Not horrible, I don't believe, but I don't know the number.
Yeah. Well, okay. Your doctor will know if it's too low.
Okay. Thank you.
That's it from me.
Dr. John, did you want to add anything?
No, I don't think so. Those were really good, thoughtful reactions from Len and Rick.
Okay.
I would really endorse them.
Thanks.
All righty.
Yeah, the biggest thing that really sticks out for me is don't do a bone biopsy.
Okay. Okay.
It's a procedure, and from a procedure, it could be common or garden, but who knows? You could get sepsis, you get something. Why even bother, to just draw some blood and send it off to the lab, for goodness sake. We have the technology to do that today, unless he has a particular reason. If he has a particular reason why he doesn't want to do it, and then come back and talk to us about the reason before you agree.
Okay.
Don't dive right in. And if you don't have time, if there's between now and the next Tuesday when Peter Kafka's in the chair, reach out to one of us moderators and we'll help you. But if you can, come back in next Tuesday and we'll knock it around here a little bit and see. But I can't think of any reason why given your PSAs at 1.6 and we can see a number of lesions and we can see them on the CT scan, never mind the PSMA scan, then I would think you'd get a successful result out of a liquid biopsy.
We'll ask the question tomorrow.
Thank you.
Thank you.
All right.
Can I ask?
Nothing shows up on a somatic test. Is that correct?
We haven't done it. We haven't done it. That's what we're talking about, to get us a bone biopsy for a somatic test, Peter.
Well, but they didn't even do a test before doing chemo, huh? Interesting.
What's a somatic test?
Somatic test would be, what is that?
That's looking at tissue from a biopsy or
Well, they did that when they did the my prostate biopsy. They sent that tissue off.
okay, and it came back negative for everything. Is that true?
I believe so.
Yes.
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 And
It
that
was
wasn't
back in
just
July.
germline. That was somatic. That was the whole panel. Is that what you're saying?
I think so.
And what he said is that because they had done that, but because the bone lesions there were so many
So many of
more,
them.
according to the bone scan and the CT scan, that they wanted to see what was happening specifically in the bone.
Okay, so it's just bad thinking because there's another. Can I just ask you what was the date of your radical prostatectomy?
I didn't have a prostatectomy.
Oh, you didn't have a prostatectomy. They sent your tissue off, your biopsy tissue off.
Biopsy tissue off, correct.
Okay. So first of all, make sure you get a copy of whatever that was. Whatever they sent it and whoever they sent it to, get a copy of that.
Okay.
Ask for that tomorrow. A couple of things that I think should be discussed, additional things. You need to talk with him about debulking the prostate with radiation, because we do that now. This is something, there's a bunch of guys. Anybody had debulking on this call? Anybody now? Yeah, Dennis has. Who's that? Larry's had it. In the old days, there was a do no harm philosophy that you wouldn't do surgery or radiation on a metastatic man. But over the past 10 years, the research has shown that it's advisable and probably radiation. So one area of radiation that can be considered is to radiate the prostate and possibly the pelvic girdle, but usually they don't do that. They just radiate the prostate. And that's called debulking with radiation.
Okay.
Debulking, yeah, Debulking. So talk to Kyriakopoulos about debulking as well tomorrow.
Okay.
Now wait a minute. What was I going to say to you? Yes, the reason why a liquid biopsy is better than a bone biopsy is because the liquid biopsy gathers DNA fragments from all over the body and all the different bone tumors, because they're shedding these little bits of DNA all the time. And if we go into a one piece of bone, all we're seeing is one piece of bone. In prostate cancer, usually that's okay because we think that it's very homologous between the different bone. Doesn't matter which bone, you probably are going to see much the same thing in each piece of bone, but not necessarily. We can't say that for sure, but that's what the research says. But that problem goes right away if we take blood, because if we take blood, we're getting a much wider sample.
All over.
It's from all over.
Yeah.
So it bothers me that Kyriakopoulos is thinking about getting a bone biopsy when he could be getting a blood biopsy.
Okay. Okay. I think we've got good notes on that, and we'll definitely get that message to him and ask.
And you know, if he's not happy and you're not happy, Lang is the guy that we know best, and he's probably Kyriakopoulos's boss, and so that's an alternative within Carbone. but
Oh,
we
it's
can
in
talk about
Carbone,
that
Dr.
next
Lang?
time.
Okay.
Sorry?
Dr. Lang is within Carbone.
Yes.
Okay. Okay.
Yeah. And then we also know a few of the radiation oncologists there too, but I can't remember them off the top of my head.
At this point, they had me scheduled with a radiation oncologist that had been at UW and is now in Green Bay. And they did that partially because it's a very involved trip for us distance-wise,
Okay.
getting to Madison. But we felt okay with that he had been affiliated with UW and is now practicing in Green Bay.
Yeah, but the issue is whether he has the equipment that
Okay.
you've got to make sure he's got the equipment that they have there and he can do the same thing. So if he
Okay.
if he doesn't, he's got to have comparable equipment. So again, you'll tell us what he's going to use, and then again, I don't want to second guessing because it may be a non-issue, but you've got to
Okay.
make sure he has the right equipment.
Yeah, and we have made it very plain to them. It's no problem for us to go to Madison, even if we have to stay. So,
Okay.
so we would make that work. That's not a problem.
Okay. All right. Well, I'll tell you who we've got left. We've got Rob. We've got Glenn, who I just saw left. I don't know if he's come back. He's been in and out a couple of times, Glenn. But we've got Glenn and we've got John Ayo. Is there anyone else that I'm missing who originally wanted time today on our first go round and I haven't spoken to? Okay, so my notes are good. So we'll go to John Ayo because he was in early and I skipped over him. So we'll go to John Ayo and then we'll go to Rob and Glenn if he comes back. Because you've got to stay the course here. You've got to stay the course to get to the end. This meeting is not a 90-minute meeting. It's a 2-hour meeting. So.
All right, so this is my second time on. So quick recap was my PSA was at 12 several years ago, and I did a biopsy in August of 20 and 4+4 Gleason. So decided to do a prostatectomy May of 2021. And my urologist said, we'll just watch PSA every 6 months. So it stayed below 0.1 for 2 years. And then last May it went to 0.2, and we went to, so we waited 6 months, probably my fault. And then we went to 1.7 in November. So I did a PSMA PET scan December 1st, and it showed multiple lesions, metastatic. And so then I've been on this journey and working, remember, I'm the natural health guy. So doing lots of things there, working with a medical oncologist, UT Southwest. So right now, it's probably been 3.5 weeks now, I've been on the darolutamide as a monotherapy. And so I was in a lot of pain last time I saw you guys in my right leg, which I had a hip replacement. And luckily, about 3 weeks, well, it's probably a week and a half ago, I got off of all of the opioids. So I went from fentanyl patches with hydrocodone, then I got off the hydrocodone, then I just was doing fentanyl, then I went from 25 to 12 and got off of it. So I've been off of that for a week and a half. So that's kind of the update of where I am, and I'm doing a blood test tomorrow morning to see what the Nubeca's doing, and feeling very good overall, but that's kind of the update. So questions are, what,
Yep.
is there any other way?
Before you get to the questions, can I just clarify something?
Yes.
When you talked to us the first time, which was, do you know when that was? Because I'm starting to make a note.
I think it was January the 15th, maybe.
Okay, because
early January.
I'm starting to add here when people first come in, which I didn't used to do, and we really should do that. I have a note that you were going to do Orgovyx and darolutamide, and you just said that you're doing monotherapy darolutamide.
Yep. So we started down that path with Orgovyx, and for some reason it got delayed, and they said, yeah, but we have this prescription for Nubeca, and it wasn't even from my current oncologist. So I said, well, send it, and it came overnight. So I started it, and I still don't have the Orgovyx, but I think I'll have it in a couple days. But in talking with the oncologist, he said, well, let's just try the Nubeca first, let's do your blood and see how it's doing with the liver, and then we'll just keep an eye on it, because I'd rather not do the Orgovyx if I don't have to, is my thought.
Yeah, I mean, to be honest, we really like that because we think it might work. So, we've got a bunch of people who are monotherapy darolutamide. David was or is, Len is now and has been before, and we've got a few other people, and it could be a real good option with less side effects. So that's really good. And if you can avoid taking the Orgovyx, it's great. And you've got a doc who's willing to go with you on that. See how you do. See if it keeps you low. That's what I
Well,
would say.
but the question is, given the story I was telling you guys, so having less than 0.1 for 2 years, and then it goes up, and it went up to 1.7. Is PSA even a good marker for me? And are there any other markers to measure our progress?
Well, I mean, it's a perfect marker because this disease doesn't metastasize right away. It hides, and then it comes back, and then it metastasizes. And sometimes people, they get it right away. Some people get it 2 or 3 years out. Some people, like Dr. Jack Baruch, gets it 15 years later or 20 years later. So, that's what the PSA is there for. That's why it was developed originally. So the marker that you want is that. Now, one thing that I would be talking about, so that I had a much better feel, before your as long as your PSA is up that level, is a PSMA scan. Have you had one?
Yeah, December 1st. That's what got us here.
Okay. So what is it that you want from what is it that you would like to see from other markers?
Well, I mean, my understanding is darolutamide is going to stop and regress the cancer and get that PSA way down. And luckily, my pain went down before I even started it, so I'm thankful for that. And I'm not sure of other markers. CEA, I don't know if there's other markers that give us an indication. Nagalase, or I don't know.
What do you want it for? I mean, we don't do tests. What do you need the marker for right now?
I don't like PET scans because of the radiation. So I'm trying to find something else and not do them unless I absolutely have to.
Okay. The answer is there's nothing else that is going to give you an accurate reading of where you're at other than a PSMA scan.
Okay.
We don't have anything, because even if we did, and there are certain other markers, and what is it, Len?
You got an LDH or alkaline phosphatase.
Yes, alkaline phosphatase, or there are, but it's not going to tell us where the cancer is, and it's not very reliable. Alkaline phosphatase has been around for how many years, Len? 30 years?
Well,
longer than that.
50 years at least.
50 years.
So not just as a biomarker for cancer, but just, it's part of the metabolic panel, even if you're healthy.
Right.
Been around more than 60 years.
60 years.
Yeah.
So, we can do it, and I get that you want to do as little as possible, but in your situation, you've got to do as much as you can to control the cancer.
Right.
To limit the cancer, and you're doing all the right things. One of the things I'd like to know is, have they ordered what sort of genomic and genetic testing have they ordered?
I just talked with him last week and asked him again, and he said, yeah, next time you come in a month, we'll do that, but it's more for future reference, not something that we need today.
How does he know that?
I don't know. That's his
Well, you
answer.
say to him, say, Dr. Wang, how the hell do you know that? You know I don't have. Have you ever had germline testing?
Nope.
So you say, how do you know I don't carry BRCA, Dr. Wang? How do you know I don't carry Lynch syndrome? It makes me crazy because when we go in and this is what we see: metastatic men who aren't getting tested, and the guidelines say you got to be tested. And the reason why is because there are precision medicines that can be invoked earlier. They may not be. That's Dr. Wang's choice. But what he cannot say to you is, you shouldn't be getting this because it could be down the road. Right?
Okay.
So
Yep.
here's my thought on this. What you really need is somatic testing. And Jeff Marchie's one step ahead of me. You can get germline testing if you want, and it wouldn't hurt. But if you're going to get the somatic testing, you don't need the germline testing until you have the results of the somatic test. Why? Because if in that somatic test, certain mutations show up that we know are very common to being inherited mutations, then we come in again and we say, okay, well, we'll just do the germline test to see if this is somatic or if this is germline.
Mm-hmm.
You're following me, right, Dr. Ayo?
Yep.
So, yes, by all means, Jeff put the link, the promised link in the chat window. But more important than that, the discussion we just had with Darryl Rohrer, we need somatic testing. And hopefully we can get that somatic testing from you. What do you think your PSA is at right now?
I'll have a blood test in the morning, so I don't know. Since I've been on darolutamide for 3.5 weeks, I would hope it's less, a lot less.
May not. I mean, you've got to give it time. It shouldn't be that much less. And I would be saying, let's get a draw. Let's get a liquid draw now.
Liquid draw for
a liquid blood draw, so we can do a somatic analysis. Don't wait a month, because you wait a month, it could reduce the amount of ctDNA that's in your bloodstream.
Okay.
So you want them to take the blood now and send it off now. You know, sometimes I wonder where these docs' head is. This ain't brain surgery. It's basic good GU treatment.
Okay. I'll get it.
So, you know, you want them to send it off. Same thing that we said to Rohrer. Tempus, Caris, Myriad, Foundation Medicine, and get it out to those guys, and then come back and talk to us about it, and talk with Dr. Wang about it. But
Okay.
you know, but I just don't see how Wang can turn around and say, well, you know, we don't need it right now. I mean, I know I know where he's coming from. He's coming from, well, let's see how you do on the darolutamide and but it may be that it shows something that may have a more appropriate drug.
Okay.
And you can always get it tested again, you know, because it's somatic, it changes. So what you have today is not going to be the same picture what you have a year from now. Maybe, but not necessarily. Germline isn't going to change. Whatever you inherited, you inherited. That's in every cell. That's cast in stone. So if you don't show anything germline today, you won't show anything germline ever. But somatic changes all the time.
Okay.
And again, I'll just say that's my view. So let me defer to other people in the group. Anybody else wants to disagree or add something, please?
Agree.
Well,
Could you
I
remind
can't say
just
more information is going to hurt us. So I would, just other than the money and the insurance or all the games we play, but I would think more information would be better too.
John, just remind me from my notes what's your latest PSA?
My latest PSA?
Yeah,
Well, 3 weeks ago it was 2.1, and I'm
2.1.
getting a
Okay,
test in the morning.
okay, thanks.
And I don't know, he was very confident. He's like 100% your PSA is going to be down from 2.5 weeks on Rebecca. So I don't
Yeah,
know. We'll see.
Daryl's pretty quick. It'll take your testosterone down very quick. Then the question is, how long will it take your PSA to go down once your testosterone's down?
Well, John, he's not on an LHRH.
I know, yeah.
But it won't, so it
I
won't.
think his testosterone's not, well, his testosterone will be functionally down, I should say. It'll still be circulating in the bloodstream, but it won't be doing any good. It won't be getting in the cells.
Right. So, but what we've sort of seen is that your PSA may not come down as quick when you're not on when you're not on an LHRH, but it shouldn't bother you because we've still, we're trying to treat the cells, but I think it probably will come down. I don't know. I'm not a doc. I shouldn't be saying stuff like that. But don't get anxious if your PSA isn't as low as you would like to see it.
Okay. I'll come back and report in when we get it next time.
Yeah.
And hopefully
Peter.
with some somatic results.
Peter, you look like you want to say something here.
No, I'm just getting a little tired. Just trying to stay awake here.
Let me share something for a moment. I was on darolutamide for 2 months.
Go on to the AnCan website.
Sorry.
Go ahead. I'm muted, Frank.
Can I share something?
Go ahead, Dr. Jack.
I was on darolutamide for 2 months before starting the Orgovyx for various reasons, and then I eventually added the Orgovyx. However, my PSA went from 2.0 down to less than 0.012 within 1 month after being on darolutamide. I added the Orgovyx because I wanted to do the doublet therapy and do the protocol the way it was designed to be, because I wanted to play it safe. But I don't know how I would have done if I stayed on darolutamide alone. So I've been on darolutamide for 9 months and on Orgovyx for 7 months. So, I would have felt a lot better without the Orgovyx. I have no doubt about it, because once I started the Orgovyx, it was a totally different feeling of devastating, fatigue and everything else that goes with it. But, I just figured they know what they're talking about, so I'll stick with the doublet for the 2 years and see what happens. But your PSA may go down within a month. I don't know. It may go down to very undetectable.
Okay. Thank you. Well, we'll see. We'll find out
So
soon.
that's why you shouldn't listen to me, Dr. John Hale, and because I'm not always correct. So that's the reason. But we think it works, and Dr. Wang is right, and maybe he's seen a lot more folks like Dr. Jack. So
We'll find out very soon.
We'll find out very soon. All right, we've got 5 minutes left, or more if we need it. Rob, are you still with us?
I am.
Good. How
Okay, you
are
can hear
you?
me. I'm
Yeah.
doing
How
okay. I'm doing cancer-wise. I'm doing pretty good. So I can't
great.
complain. So just recap. I had Gleason 9, and I don't even remember anymore. Most or all scores that they tested. Gleason 8 and 9 on one side, Gleason 7s on the other side, and a couple suspicious lymph nodes. So they started me on a ADT back in November of 22. I was supposed to start radiation IMRT in February of 23, except there was a snowstorm, so everything got readjusted. So my IMRT started in April. So I had IMRT in April. At the end of that, we added abiraterone, and since then we were doing every 6 weeks PSA, and PSA has been undetectable every time. Last PSA was in early January, still undetectable. So I'm doing okay. Have plenty of issues, in the family, not related to cancer, but cancer-wise, I'm doing okay.
Well,
So I
I'm
just thought I'd
sorry
give
to
an
hear.
update if I hadn't been here in a while.
Well, we're sorry to hear you've had issues in the family, but we're very pleased to hear that you are undetectable. And when are you plan to come off of your hormone therapies?
Well, the plan was October. It was original plan was 2 years.
Okay.
October would be the end of the 2 years.
Okay. And how are you managing in terms of how you're feeling on the hormone therapy and the fatigue, the hot
Well,
flushes? The
I don't know that I've had proper hot flashes until maybe a couple nights ago.
Oh, right.
When it seems severe. Other than that, I haven't noticed hot flashes. Fatigue, yeah. I had been exercising through about regularly through about Thanksgiving, when other things derailed my family life. And then I've been having back issues since the new year. So I have a couple of bulging discs that they need to take care of later this week. So, so right now, getting up and walking is very difficult. But hopefully, it will take care of the bulging discs, and I'll be back on my feet in a couple of weeks.
Well, the exercise is really important. I don't have to tell you that.
Yeah.
And anybody here in the group suffered from bulging discs and found a way to exercise with the bulging discs? Jack, did you put your hand up?
Yeah. I got a lot of bulging discs, a lot of degeneration, neck and lower back. And I find the best thing for it is to walk. Just walk and walk and walk and walk, and not run.
Yeah. Right now, walking greatly exacerbates the nerve pain all the way down my left leg.
So maybe
It
that's
brings it
part.
up to about an 8 or a 9 on a
Yeah,
scale of 1 to 10.
spinal stenosis. You got to check that.
So,
Any other thoughts for Rob?
I always recommend a book by a physical therapist called Robin McKenzie. I don't know if anybody's heard of him. He wrote a book, very small book, maybe 60 pages. It's called Treat Your Own Back. And there are fantastic exercises in there, very simple to do, that that should help. It helps anybody who's ever had back pain, and I've either given them the book or they purchased it themselves. They said it helped a lot. The idea is to what they call maintain the lordosis, that curvature in your lower back. And there are exercises you do to bring that about.
Len, would you put it in the chat so we have a record of it and we can include
Yeah,
that?
yeah, sure. Should I look for it on Amazon and put in a link, or just the title?
Oh, I
You
think
can
just put
you
the
can
title.
you can Google it. It's $25.
Oh, I didn't know it was that much. It used to be, I've been recommending that for a long time. It used to be $12.
Well, I would say just put the title in, Len,
Yep.
but you know, I think it's a good suggestion. So it's, you know, it's not, if it works, the extra $12.50 is not a huge
Yeah.
investment, I would say. So and I'm just looking through here. It's kind of hard for me to answer personal questions in the chat when I'm moderating, and which you should know. Okay. Okay. So, is there anything else? Is there anyone else who wants to raise anything tonight? We're only a minute over. It's pretty good. Well, we didn't have any new people, so that's sort of cheating on my part, because I was able to let everybody talk and plenty of time. Is there anybody on? Is there anybody who? Billy, I just saw you. Have you been to see Elizabeth? Have you been to see what's her name yet? Elizabeth? What?
Elizabeth Heath. No, it's next Monday, but I was just going to ask if you saw her.
No, I didn't see her.
Oh,
There's a
okay.
bunch of people I didn't see this year. The strangest story of all was that, well, it wasn't the strangest of all because a lot of funny things happened. But I had a meeting with Arvinas, Arvinas, who make the androgen receptor destroyer. This is like an enzalutamide that just totally blasts out the androgen receptors. And the meeting was courtesy of Len, because originally Len introduced me to this very nice lady, Ashley Doyle, and she reached out to me and said, "Will you be there? And we'd like to meet." And they work with some docs we work with, and later in the year we will probably do a webinar with them on these androgen destroyers. And she had a lady with her who was their director of clinical trial recruiting. And after the meeting, she talked to me a little bit, and she told me that her dad had just got diagnosed, but her dad had issues with a couple of growths, and he was getting biopsied, so he hadn't been diagnosed yet. And I said, "Where?" And she said, "UNC." And I said, "Well, frankly, I wouldn't go to UNC. I wouldn't go to University of North Carolina if that was an option. I'd go to Duke. I think it's a much better cancer hospital." So we agree, and I said, if you reach out to me after you've gotten the results of the biopsy, we can set you up. And there's a doc we really love at Duke called Dan George. He's been around us a long time, and Len knows him well. I know him well, and he's a great guy. And I usually see him. I said, I usually see him at this meeting. I haven't seen him. I went out, and it was right at the end of Friday, and I had to go get my bag from the bag drop because I was going on somewhere else later. And I went in the John. I came out the John, and I went up to the bag drop, and who's standing at the bag drop getting his bag? Dan George. So I did bump into Dan George eventually. We had a lovely conversation. And he said, of course, I'll recommend somebody to you. But this is, why do I tell you this story? This is one of the big reasons I go. Because when you bump into these people and they see you and they know your face, you can write to them and they'll respond to you. So you build these connections over time. But no, I didn't see Dr. Heath, unfortunately. I did see Misha Beltran. I did see Len's Florida doc, Guanciale, but only from a distance, so I wasn't able to say hello to her this time. But, it's a nutty meeting. I mean, it's just, there's so much going on. There's so much going on. I think next year I'm going to have to take one of my Brains Trust with me. So, because if you've got a room, you can put two people in the room and we'll figure it out. But it's a great meeting to go to. All right. Now, is that it? Are we all done? Oh, Jeff Wood, did you have it? Oh no, you're just stretching your fingers. So, okay. All right, we're all done.
Rick,
We'll get this.
Rick,
Yes.
I did go to Amazon, and Treat Your Own Back is only $15.95 at Amazon.
That makes more sense.
And Len, what did you just post in there?
Oh yeah, I saw it advertised online used for $2.99.
Check
Hey,
your
Rob.
library too.
That's right. And Rob, we only ask for 10% of what you save. You know that, right?
There
Just
you go.
kidding. Okay. All right. Good night, everybody. Good
Good
meeting.
night. Good
Good
night.
night.
Right.
Thank you, everyone.